So welcome everyone, and thank you for joining us for today's webinar titled Versatility of the inHEART Solution in Complex Ablation Cases. We're joined here today by Dr. Yarmohammadi, who's the electrophysiologist and assistant professor of medicine at Columbia University, which we've been talking about on the slide here in front of us. And our guests will be sharing, Dr. Yarmohammadi will start off by sharing case reports highlighting their use of inHEART platform to guide complex ablations in LVAD cases, congenital repair patients, and non-ischemic dilated cardiac myopathy. In addition, we are pleased to be joined by two guest panelists, Professor Hsia, electrophysiologist and professor of medicine at University of California in San Francisco, as well as Professor Sacher, professor and electrophysiologist in Bordeaux. My name is Katie Arnold, and I will be moderating today's conversation along with my colleague, Jody Lombardi. We'll be recording today's discussions for use online and to share with clinicians. So your continued attendance on this call will serve as consent to the audio and video recording, as well as its distribution. Our format today will include case study presentations, followed by Q&A from the panelists, as well as from attendees. We encourage you to submit questions throughout the presentation in the Q&A feature at the bottom of the screen, and we'll work to incorporate your questions into the conversation. So without further ado, let's get started. Dr. Yarmohammadi is going to kick us off with his presentation.
Thank you, Katie. Thank you, Jody, and thank you, inHEART team, for the invitation. So I'm going to start with the case of LVAD patient. Moving forward, hold on one second. There you go. All right, so my disclosure, as you see, let's start with the case. So this is a 69-year-old gentleman with the mixed ischemic and non-ischemic cardiomyopathy. So his ejection fraction was around 20 to 25%. He had history of diabetes, hypertension. He had a peripheral artery disease and single chamber ICD Biotronic with AtriSense RV coil was implanted 4 or 5 years ago. And then he was in Florida at the time. He was hospitalized for ventricular tachycardia. They found that he has a monomorphic VT. They had an unsuccessful endocardial ablation, so it was still inducible at the end of the procedure. So they placed him on amiodarone and mexiletine and then discharged the patient. And the patient came back up to New York City, where we are. And about a month later, he developed a VT storm, and he showed up with in cardiogenic shock. And just FYI, TSH was normal, and despite being on amio, the thyroid function was stable. He was started on amio on lighter drip again, but he still had runs of slow VTs, about 120s to 140s, that kind of range. But still, he was in cardiogenic shock, so he received a balloon pump, and he was evaluated by LVAD for LVAD implant. So when we saw the patient had two components. One was a VT that it was keep running despite two strong medications, as well as incessant heart failure. So he had indication for LVAD implant. So we, after discussion, we plan to do a VT ablation during the LVAD implant. And this was his EKG, one of the EKG that he had a run of non-sustained VT. So as you see, it's very disturbed EKG with a lot of significant QRS abnormalities. So he had some run of atrial tachycardia, AFib once in a while. And then he goes to this at the end of the strip. You can see that he goes to this pattern of monomorphic VT, is regularized now. And then, unfortunately, we didn't have a 12-lead EKG of the VT. We just have the last half, which we caught in one of these non-sustained VTs. And what it tells you basically has very apical and very slurred initial force. The mapping they did in Florida favors more epicardial location or intramural location. And that was basically the conclusion. And then here we noticed that it was coming more exiting apically. You see some fusion beats, and then monomorphic VT at the end. So since his kidney function wasn't bad, he was within the normal range despite a cardiogenic shock, we sent him for inHEART CAT scan. And we got this beautiful CAT scan. As you see, we have the balloon pump seeing in aorta here as well. And we had a good description of the thin and thickness. So here are thicker area, thinner area, and the yellow, light yellow is favor more thicker area. So this is more favor scar area. This is more favor relatively healthier. And here, when we don't see any thinness, and this is basically healthy area. And they were able to provide the phrenic nerve. I noticed that the phrenic nerve area, the channels usually close to phrenic nerve for some reason, because our life more difficult. And then we have a very good description of the venous circulation, arterial circulation. So we had a sense because of this that where we need to map and where we need to intervene. And we were thinking about exiting laterally, more towards the apex when we were taking the patient to the LVAD and mapping during LVAD implants. So one of the issues with the LVAD implants is they wanted things to be done very quickly. So you don't have much time like what we do in the EP lab, like 4 or 5 hours of mapping and ablation. You have, especially in our system, they don't give you more than 20 minutes or 30 minutes time for you to do the mapping and ablation. So that's one of the things that inHEART CT scan help you, and it will tell you that what are the area that you can focus. So basically what we do is when the chest is open, it's still on the pump, we fill the water around the hearts because in the case you wanted to make a map, you need to have an impedance protected field. So we put a saline, we put our HD grid, and this was a during sinus rhythm basically. And we basically map the area. This is the healthy area. This is a little bit of, this is a scar area. And you see there's a very interesting potential area correlated with the CAT scan that we got that has a late potential. We were able to induce VT. That's a different story, how we induce the VT and how we can induce VT in these cases. But after induction of the VT, we map it quickly. And we found this is the pre-systolic, and we had a mid-diastolic, which I don't have a picture there. So we found this area that correlates well with that area of the late potentials, have a very nice mid-diastolic potential, and we were able to ablate it. Now, where is my next slide? Oh, there you go. So this, we use a cryo. This is the picture I used from another paper. It was very correlated where we did it. They did the RF here, but we use cryo for ablation. We're not allowed to take a picture at Columbia. There's a lot of restriction about doing OR imaging. But nevertheless, we moved the heart. We put 3 cryo lesions across the area of the interest, and it was rendered not inducible at the end. And then when we follow up the patient, or now we did it in 2021, is up to 3 years. There was no more VT after that, which is a very significant for patients that have LVAD. So let's go over some of the data about patients that are getting LVAD. So one, we're getting a lot of LVAD these days because there are new LVADs that improve the survival, especially HeartMate 3 showed a lot of benefits comparing to the older ones. So they survive, they'll live longer. We expect that we get up to 150 to 250,000 patients per year with LVAD. So it will be a significant population of patients that we're gonna deal with. And they will live long enough. They're not gonna die in a few months. They're gonna live like 3-4 years at least, and even more with the new changes. There are another changes happening for HeartMates too. And the post-LVAD VT is very common. So up to 20 to 25% of the patient, in some studies, up to 50%. Like 1 out of 2, they get VT post-LVAD. Now, there are things that predicts this. The strongest predictor of VT post-LVAD is VT pre-LVAD. So if you already have VT, when you get LVAD, you will have VT very likely afterwards. Now, LVAD itself can cause VT, especially if you have apical scar, if you have substrate over there. When they put the cannula, they can introduce new VTs as well. And another important facet here, another important note is when you have VT and VF versus no VT and VF, your chance probability of the death increase significantly. Significantly, you will have a higher death. So it's very important to ablate the VT during the time that you're implanting the LVAD. Because even post LVAD, you will have some challenges. There's a high recurrence rate. There is a problem with the mapping because of electrical interference. There's a problem of the RV failure. You will get a right to left shunt because left atrium now has a lower pressure. We had a patient that had a cyanotic complications after that because just right to left shunt. It's difficult to access epicardium after the surgery. So all of these, although we have one patient, another cohort that we had, that we went and to do ablation. And he, despite getting rid of the VT, that he did poorly after the second chest opening. So it's very difficult to do it post if it's especially epicardial, but during it can be very successful. And what will help us is this inHEART images that decrease the time of the mapping and improve our success rate. Now, also we published a bunch of other papers about the use of inHEART imaging. We were able to, yes. So we had 8 patients. We didn't see no recurrence in 7 out of 8. And another one that had a recurrence wasn't the location of the VT before. This is intra-op VT ablation outcome of our group. We are about to publish that. We're almost done with the writing up the data. And yeah, there are some limitations, as I said. Okay, so and these are the papers that we publish on the benefit of inHEART in patients that we do, we do imagings before the ablations. And we were able to actually, from the CAT scans, to identify the locations of the circuits with high accuracy. This was published recently in Heart Rhythm. And just from the CAT scan, you can identify the channels. And this will be, in particular, very helpful for patients with LVAD. And I see a growing need for identification of these channels and ablation intra-op. So I think this inHEART is very helpful in that means. All righty, thank you. Ready for questions.
Thank you, Dr. Yarmohammadi. I'll open the questioning up to our panelists and other presenters to start with their questions. Attendees, just a reminder, there's a Q&A feature at the bottom of your screen. Please feel free to submit questions throughout the course of the webinar for any and all of our presenters.
Well, maybe I will start with a quick question. Dr. Yarmohammadi, do you think that in the future, can you identify or do the a pure anatomically based substrate ablation without even doing any sort of mapping intra-op? Because that's always a technical challenge, as you know.
Yes, that's the hope, that we can get a better imaging and we can identify these channels with the more accuracy. One of the problem is it's tough to induce VTs when you are heavily sedated, intubated, and some on occasions is your nerve is paralyzed too, so with all these medications. And then out of our cases, we were able to induce only 3 of them. And some of the patients have subcu ICD these days. It is very difficult to induce that in the OR. We tried to use the quad and use a temporary pacing. So yeah, I mean, for these cases, I think we will rely on substrate mapping and substrate ablation more than our endocardial, epicardial, EP lab type of patients.
Maybe I have another question. How does it help you to plan your strategy? I mean, and it goes with what you have just said, planning to go epicardial or endocardial, or whether you see something intramural, maybe change your strategy. How do you use it to help you in this for that kind of things?
Yes. So first, surgeons wanted to know exactly what we're going to do. So, and when I showed them the images of the CAT scan and the planning that we have, they are more supportive. of the, our ablations, because it's not easy for them. They are basically under a lot of pressure to finish the case faster and then less complication. Now, sometimes most of our cases, we already have endocardial mapping. So there's some information about how the VT behaves. So we have pre-procedure data. In this case, we have a map from Florida. We had an EKG, and we had some information to begin with. Having said that, I believe even if it's an intramural, one of the things I do is, especially with the cryo, I'll put a lot of pressure. So it's not only ablating with cryo, I put more pressure to get a deeper lesion when I'm ablating intra-procedure. So I think even if it's intramural, it's not 100% epicardial circuit, we will be able to narrow it enough, that area, and then make it, render it non-inducible. Also, I add some ablations around the cannula, so to prevent future circuits from that. So there's some flavor to it.
Maybe I will ask another quick question. Do you find that in cases like this, is CT scan more preferable over MRI? And or going back to the old days of subendocardial resection, do you recommend the surgeons actually perform, as they are under the time constraints, so they probably will not perform any additional surgical ablative modification of the substrate? So I guess there's two questions. One is a CT versus MR, and whether or not you think that a surgical intervention in addition to your ablation that will be beneficial.
Yes. So both are very good questions. CT has some benefits. One of them is fast. For example, in this case, we have the balloon pump. We can't do MRI. The second thing is our MRI systems are not as good as some institutions. So we get a lot of noise and artifact from our ICD leads, especially, especially around the apex. It's very difficult to assess the apical area, maybe basal area. You can still see something. In case of CRT, that also goes away too. Another thing is the patient is not comfortable to stay long for getting MRI. And the resolution that we have with the CAT scan is much better. And the only limitation that we have, of course, is the problem with contrast and the kidney function. Another thing is most of these patients come in the cardiogenic shock before LVAD. So these are inpatients, and movement is very difficult. Keeping the patient in setting up cardiogenic shock in MRI suit is difficult. So I usually go with the CAT scan, which in this case was very helpful. I noticed that surgeons try to finish cases as fast as possible. They are very, the data about being on pump for a long time, they have this limitation of time, and they are very resistant sometimes to do cases, especially, 2 days ago, I had a patient I want to do another ablation, but he is a redo. Because of that, they don't want to take even 20 minutes. So these are the limitations that we have. Hopefully, we can have better collaboration with the surgeons, and we can do these cases more often. They need our data too. So when we do more and when they see the good results, because they will face the VT after LVAD, there will be a lot of challenge. There are inotrope just coming out of LVAD. They go to VT a few days. They stay longer in the hospital. So not having a VT is very significant. And if they see that we are doing great mapping, the great results, I think there will be a shift in their mentality, and they're more willing to do cases with us.
Well, thank you, Dr. Yarmohammadi, for sharing your experiences with inHEART. We're going to move to our next presenter, who will be Dr. Obeng-Gyimah. And if Dr. Yarmohammadi, thank you. Yeah, so we'll get ready with the next presentation. Dr. Obeng-Gyimah is the Director of VT and Complex Ablation Program at WellSpan Health. in York, Pennsylvania. So we welcome you, Dr. Obeng-Gyimah. You're going to be sharing the utility of image integration in the non-ischemic DCM population.
All right, can you guys hear me?
Yes, and do you want to, if you have a presentation, please feel
Sure.
free.
Yeah, I'll share that. Can you see my screen now?
Yes, we can. Thank you.
All
Oh,
right.
do you mind, because you're just going up to display settings and selecting slide presentation mode. It's in your top left of the nav bar. Next one over. There you go.
This guy?
Nope, next one.
This guy, okay.
Yes, and there you go. Just go to the first one, swap presenter view and slideshow. There you go. Thank you.
Okay, it's working, okay. All right, guys, thanks for your time. Good to meet you all. Good to see you. Again, my name is Edmond Obeng-Gyimah. I'm one of the EPs here at York, Central Pennsylvania, with WellSpan Health. And I'm honored to join you guys today to talk about my experience with inHEART, a 3D reconstruction program, and its utility in VT pertaining to dilated cardiomyopathy patient. I've been a user of inHEART for about 3 years now, and I think it's really helped our program a lot in terms of especially improving our efficiency of the procedure. So I got a couple of cases to share, and then we'll talk more about our process. All right, so I'm going to present a case here. First case is that of a 75-year-old man, history of diabetes, hypertension, obesity. Initially came in with dizziness and palpitations, and he was noted with high burden of VT. He'll be in VT for 30 minutes, and he stop for about, 1 minute and go back in it again. He was failing. The VT was slow, about 150 beats a minute. He was failing amiodarone, IV amiodarone, and lidocaine. Echo showed EF low, 35%. He had a cath that was negative. Left ventricular EDD was 5.8 centimeters, so that's pretty enlarged. You can see the echo at the bottom, image. And we did an MRI. Fortunately, we were able to really get MRI quickly here. Our team, imaging team, really do a very good job with accommodating our urgent patients. So we're very lucky in that sense. So the MRI shows septal scar. As you can see here, I don't know if you can see my pointer here, right? So this is essentially short axis of MRI. You got here it's LGE. You got here the RV. You've got here the left ventricle, and the whitish within the dark is the LGE that we've seen here. So this is a VT, as I'm showing you here on the telemetry. So essentially, we did we send the image to inHEART. We're not able to get a CT scan for this patient, so we got an MRI, and we send the image to inHEART. And what I also like about them is that he actually able also to give you the 3D rendition of the ventricle within a really limited amount of time. I mean, I think in this case we were able to get our 3D reconstruction back within about a few hours, 3 to 4 hours, if I remember correctly. So that can be very helpful in terms of the urgent cases. So this is essentially what they found with the 3D rendition. Essentially, you've got your, I don't know, you guys see my cursor moving or not really? No? No, okay. So I don't have any pointer system here. So what we're seeing here, you have the LV, right? And then you have the LGE. The red is really your aorta, and you got like the blue lines there showing your coronary sinus system. And then you've got your patchiness here in the scar, the dark blue being your dense scar, LG on the MRI, and the lighter blue is scar, but not dense scar. So you can see clearly that, the entire septum, from the base of the septum all the way down towards the apex, had this stripe of scar within it. Etiology was not clear to us. I would think likely a myocarditis picture. So we've got a lot of other testing coming up, but essentially this is the information that we have with us going forward with the ablation. And with the morphology of the VT, which I'll show you, I think I just showed you the telemetry, but I'll show you the 12 lead soon. So with the 12 lead morphology of the VT and this scar, we really knew where to start. Right? So we brought him into the lab. The VT was really easily inducible, right? So with just RV burst pacing and a little bit of prel, we were able to induce a VT quite easily. Again, as I mentioned earlier, slow VT, 140 beats a minute. This is a pacing on the left side, and the VT shown on the right side. The ECG in the red that you're seeing is the patient's VT pre-ablation, and you can see that is very similar to the VT that we induced during ablation, and it's the same clinical VT. Okay, so again, in looking at the location of our scar on the MRI from inHEART, we knew that we're gonna be dealing with more of the aperceptal scar, potentially where this VT is coming from, somewhere below the right-left junction, maybe on the mitral annulus. So that's sort of like where we're thinking, and we proceeded as such. All right, so essentially, we go into the lab. Our process is quite straightforward. We go in. The first thing we do, we get baseline ICE images, and then we create a 3D ultrasound of the left ventricle through Cardo sound. We usually use Cardo to do this. So, and after we create our 3D ultrasound, then we merge with the inHEART 3D reconstruction for us. So you can see here that, the gray that you're looking at is just a 3D ultrasound, right? And the blue is a merge of the 3D from inHEART, and it looks pretty good. And one thing that we also did with a baseline voltage map, right? So as you can see, the dense map, dense scar and the scar really match very, very well with our voltage map and the inHEART 3D reconstruction. So, and again, you can see we did a very limited voltage map, right? And again, that's one thing that inHEART also is very helpful with, because we know the VT morphology. We have limited voltage map, we have inHEART, so we really know where we were going to do the work. So I think we don't really have to spend an entire hour trying to understand, essentially, do a full voltage map. Sure, if we had other VTs that we thought were coming from other places, we'll spend the time, but the patient had one morphology VT, and based on the information that we had going, we just paid attention to this basal septal region of the ventricle. All right. So one of the best ways to, just to mention this real quick, one of the best ways to really merge is these are, I don't have any pointers, so it's very difficult. If you see the green circles, we have the aortic valve, right? There's a green circle, there's a purple circle, and then it's a brown circle. The green circle is the left main, the left cusp, and there's a little bit of like small yellow equal sign coming out of that. That is the left main. And the purple circle is your right cusp, and the brown circle is going to be your non-cusp. So we use that, and we also use the bifurcation of the pulmonary arteries on ICE. We think that combination, as well as using the CS OS together, really help us do a really nice merge with inHEART. So that's sort of like our baseline to start with. All right, so we take the guy in there, we put a catheter in there, retrograde aorta, just based on the basal septal aspect of where we think the VT was coming from. And then clearly you can see that at the border zone between the scar and normal tissue, that is really where we got our best activation map. You can see clearly there's mid-diastolic potential there, and it's very early 75 millisecond pre. If you look at, that's map 1 and map 2, you can see that signal, and map 1 is our uni. It looks decent. So, we thought this was a really nice area after we mapped around the entire region. And then here on the left screen here is our activation mapping. You can see there's like a red dot showing our best activation. And on the right is essentially the inHEART superimposed on our voltage map. Okay, so you came on that region, and within about 8 seconds, the VT clearly slowed. from 370 to 397, and it terminated. Okay. So we went ahead, we just clustered the region here. I mean, there was a lot of really interesting signals within the entire region, so we clustered it. You can see that I didn't really go all the way down to ablate the rest of the scar distally because I didn't think that was really important to our VT. So we just clustered it there and we tried to reinduce again. And with 500 triples, we didn't get any VT. We put them on a lot of Prel. Nothing happened. So it's been about almost 9 months now. And the patient has a no recurrence. You're looking at we put in loop recorder. Usually I would give an ICD and the patient with septal scar, he's got sustained VT. But with this patient, there was a risk of infection. He had osteomyelitis, a multiple infection. So we didn't think he was really an excellent candidate for ICD due to infection risk. So we just put in a loop recorder. But fortunately, without VT, repeat echo showed EF about 55%, and the loop recorder that we inserted showed no VT. So really good result for him. All right. So I'll touch on this real quickly. I think, how am I doing on time, Jody? The rest of the crew? I can't hear you.
You're doing good.
You're
We'll
good.
probably need to transition over in about 5 to 6 minutes.
Okay, sure. All right, so I'll go quickly. All right, this is a really nice case also. This is a second case of a 74-year-old with mixed pictures. Got both ischemic and non-ischemic cardiomyopathy. EF is very low, 20%. He had frequent VTs and shocks. He was failing amiodarone and mexiletine. And he mostly had one morphology. We didn't really have 12-lead morphology, so we did NIPS. And the NIPS showed the 12-lead morphology, as you can see there. So just because he's failing amiodarone and mexiletine and is having shocks, it makes sense that we'll bring him in for another ablation. You can see the video here of echo. It's very, very dilated, right? You don't really see significant regionality to this. Very dilated LV. Usually we would get both MRI and CT scan on our patients because we have the availability to do that. And I think they present different information for you and they're complementary. But in this case, the patient had abandoned epicardial lead, so we just had a CT scan. And again, we're able to get it, quite expeditiously here. This was an outpatient scheduled procedure, so we also had time. So as you can see here, that is the abandoned. I don't have a pointer, so I'm sorry about that. I'm just showing you the X-ray and the inHEART CT scan that we are sending. They did a recognition for that. The reason why I put this out there, I just wanted to show you, just like my compatriot showed early on, the level of detail that you can get with this inHEART 3D imaging. It's just incredible. You can see on that imaging here, the white mesh on here is the watchman that a patient had, right? I mean, the level of, the extent of which you can see all of these things are quite helpful for procedures. And the red obviously is your aorta, and you're going down with your branches, and you got your atrium there and so forth, and all the phrenic nerve and all the things that have been described to you earlier. So essentially, again, the CT scan, when you send it to inHEART, it gives you a lot of information, right? They have scar information, you have what we call thinning information, just like the previous guest alluded to. So just here, I'm just showing you the left image, you're looking at the LV inferiorly, on the right one is the aerial view. And I've got some explanation here, right? There are thinness. The CT scan is looking at thinness, and based on the thinness is going to assign it a color, right? So the thinner the part of the ventricle, the darker the color that is assigned to it, right? So for 1 millimeter is very dark red. As you can see there, for 5 millimeter is going to be a light yellow, and so forth, okay? So we bring this guy into the lab. He essentially, even before we did anything, before intubation and sedation and all that, he just went into VT. And I'm just comparing the VT that we saw in the lab, which is in like the green on the black background, and the VT that we got from home, through the non-invasive program stimulation is on the right side. It's very, very similar, right? It's right bundle, superior axis, transition is pretty late in V4, V5, right? So we're thinking basal to a little bit mid inferior wall of the LV. Okay. So again, just like I mentioned before, what we do is we get a detailed ultrasound a reconstruction of the left ventricle. And then on top of that, we do limited voltage mapping. Again, you know, I can't emphasize that enough. Before I had inHEART, sometimes I had to spend, you know, an hour or more to get a detailed voltage map, you know, where to start and so forth. But I had that information, and you can see clearly that voltage map and that of the inHEART 3D reconstruction match very, very well. You have this really dense basal inferior scar region here that we've shown you. Again, there's some scar at the other parts of the heart as well, right? Because this patient is showing up, you can see there's a lot of scar all over the heart, right? So if I went in there and I said, all right, well, let me just do substrate modification, well, that may take me a whole day to ablate the whole heart. But I think having this and having the VT morphology and having all this information together really helps you to be more precise, and it saves a lot of time for you. So essentially, this is just telling you that, you know, our merge with our voltage map and 3D ultrasound really matches very nicely with the inHEART images. Okay, so then, you know, we got the guy in VT. You can see clearly this is some of the signals that I'm showing you here. And, you know, very low fractionated multi-component signals right in there, just matching our information. And even what is interesting, you know, this is just showing you how precise the inHEART 3D picture can be. You see my ablator here is in the dense scarred region, right? You can see red on the voltage map, and then you can see clearly in the dark on the inHEART image, it matches very nicely because you look on my ablator, there's no signal, right? And that matches very nicely to the inHEART picture of essentially not a whole lot of tissue, active tissue ongoing. All right. So, unfortunately, because this patient's VT was kind of like start and stop, we couldn't really maintain him in the VT to perform entrainment mapping and so forth. So we relied a lot on pace mapping within the scar to kind of like define the circuit, so to speak, right? So essentially, we'll pace to make sure whether we have a good pace match. And when you have short stem to Q, we call it an exit site. If we have long stem to Q, we call it an entrance site. And then if you have missed them to Q, would define that as a putative isthmus. So when we did all that, we kind of like were able to identify the VT circuitry around this scar area here. So here, this is one of the pace mapping we're doing here. You can see there's long stem to QRS, and we'll call that the entrance of the circuit. And this site we call it's mid stem for us, so we call it the isthmus. Putative isthmus, and this region we'll call it the exit of the circuitry just because of the short stem to Q. Now, this is all approximation, right? Because we don't have like the continuous VT to do it, but you know, we use what we get, right? We use the inHEART information, we use scar information, we use all of that to help us be efficient as well as effective. Okay. So fortunately, you know, when we were ready to ablate, we put a catheter near sort of like the early part of the isthmus region based on our pace mapping. As soon as we did that, actual VT was induced. So we came on an ablation and VT slowed and terminated nicely. So that was a very good result for us. So in the end, what we did is that we just clustered the basal inferior region with lesion set, just to get rid of all lavas, all fractionated signals until there's no capture with high output pacing. And then in the end, this is 500 triples on trail and so forth, and we couldn't induce any VT. So, I mean, after this, we're quite satisfied. You know, you can ask, well, there are other scarred region. Are you going to do anything about that? I mean, I don't think it was necessary at this point in time because there was one morphology VT. We had inHEART images that help us really identify the scarred region, matching with our voltage map. And our ablation looked pretty good without induction of VT. So we ended there. And that was that. So thank you very much. I'll take any questions.
Thank you, Dr. Obeng-Gyimah. I think we have time for 2 questions from the panel.
Maybe I can start if there's no question from the audience. You mentioned that you were using MRI and CT scan images, and those are complementary. Can you tell us a bit more what you are waiting for each of these exams? And if you have just one to choose, because you can have one, which one would you prefer to have?
Yeah, that's an excellent question, Dr. Sacher. Thank you for that question. So usually when I have a non-ischemic picture where there is really, I don't see any significant thinness, not on echo or even other images, then I think MRI is helpful because then it can look at more of the LGE that you can focus on. But usually when you have ischemic cardiomyopathy pictures where you have a lot of thinning and specific regional motion involvement, I think that is when CT scan actually shines very well because it's able to give you really nice pictures. Sometimes it can tell you some isthmuses as previous guest was alluding to. So our really method is depend if the patient is purely ischemic cardiomyopathy, my go-to is going to be the CT scan. If the patient is purely non-ischemic cardiomyopathy, usually MRI will be, if I have to choose between those two, I'd go for MRI. That's sort of like our go-to usually. Thank you.
Yeah, maybe I don't know if there is any other question, because I have a follow-up one otherwise.
Go ahead, Dr. Sacher.
Okay, just one point with CT scan now, we do have late contrast sequence 8 minutes after. We can give you kind of delayed enhancement on MRI. It's not exactly the same, but at least when you cannot have MRI, this can give you a rough idea of where the scar is, even if there's no wall sealing. So that may also be helpful to identify intramural scar or so ever. What about merging? So what structure are you using? You mentioned you were doing a little bit of a map. Are you using pulmonary artery bifurcation, CS, LA? Can you tell us a bit on that?
Excellent question. And I'd like to actually expand on that a little bit. When I started doing inHEART, one of the problems was really initially the merging, right? So for any new guys who are going to start using inHEART, this is really important kind of like tidbits to note. So yes, pulmonary artery bifurcation, CS oscillation, the aortic cusps, and sometimes I can annotate the left main on ice, right? You can see the left main coming out right under the left cusp. So those are really the big landmarks that I use, and most of the time they work very, very nicely. Now, occasionally, I run into issues where I'm having difficulty with the apical kind of like merge. So what I would do is I can just put an ablator way into the LV and get a little bit fam of the apex, and it merges out beautifully with these techniques.
Thank you. I think there's a question
We
from
do
the
have one
audience.
question. Yeah, we do have one
Yeah.
question from the audience coming in. What about pre and post ablation in heart scan? Has anything been done?
Yeah.
If anything has been done, how does ablation change in the model?
Yeah. Well, that's also an excellent question. Actually, we recently published a paper on a patient that had epicardial VT, but we couldn't get to it because of valve surgery and bypass surgery. So we couldn't do the usual percutaneous epicardial access. So we actually did the ablation with PFA, that we did it from endocardially, and we were able to terminate VT from epicardially by using PFA. So we did do post imaging to really see how that structure changes post ablation, and was quite impressive. Because you can see clear differences pre and post. Now, bearing that, we don't usually do that. I mean, that was a unique case for us because we hadn't done that before. It was our first case. But bearing that, I don't usually do that routinely, pre and post. I would, let's say, if I did imaging on a patient who's coming in and have recurrence, let's say within more than a year of the procedure, I may want to get another imaging to make sure that I don't have significant change. But otherwise, I don't usually do a lot of pre and post, except in those unique situations that I mentioned.
Great.
Well, thank you, Dr. Obeng-Gyimah. That was excellent, excellent 2 cases. We are now going to be transitioning to Dr. Combes, a senior electrophysiologist, joining us today from France. So I know we are short on time, but we are going to allow the webinar to go a few minutes over so that Dr. Combes, you can have your full case presentation, which you'll be sharing with us today, inHEART imaging utility in congenital repair patients. So we look forward to that presentation and discussion.
Okay. Hello, everybody. Can you see my screen?
Yes, and it is in perfect presentation.
I'm sorry, I'm not sure it's my screen. This is the screen of Jody, no?
Yes, I'm sharing your slide deck for you, Dr. Combes. So just let me know when you want me to advance.
Can you share me my computer to move the slides, if it is possible? But no, I don't know.
No, I think I'm going to have to move the slides for you. So you just tell me next slide and I'll move forward.
No problem. Can we see the first one, please? Okay. So, hello, everybody. My name is Nicolas Combes. I work in Toulouse and in Paris, and I'm involved in congenital heart disease patient and arrhythmia in this patient since 18 years in two tertiary centers in France. So we love inHEART modeling for this patient. I am going to show you why. So next slide, please. As you know, perhaps we have an increasing adult population with complex congenital heart disease. This population is higher than the pediatric population, actually, in our countries. Arrhythmia is the first cause of hospitalization in this patient with important mortality and morbidity. If we look at complex congenital heart disease, up to 50% of patients can have arrhythmias during their life, up to 50% at 50 years old. Next slide, please. What we have to know, we have different substrates associated with different congenital heart disease. We have a lot of atrial reentry, but we have also a lot of VT and sudden death in this patient, associated with scar, with sequela from surgery and hemodynamic compromise. So when we deal with this patient, we need to have this representation of arrhythmia. And in the same patient, we are going to have a lot of arrhythmias, different atrial arrhythmias and different ventricular arrhythmias. Next slide, please. For these arrhythmias, most of the time, we need to go to ablation in first line because we have low efficacy of pharmacological treatment with frequent contraindication and adverse effect. Nowadays, the success rate of ablation for supraventricular and ventricular ablation is around 80%, with a lot of recurrences and with some complication, and we need to decrease these recurrences and complication and increase the success rate, and 3D modeling can help us for that. Next slide, please. Why? Because ablation in this patient had a lot of particularities. First, we can have very difficult access. We can have some problem with inferior vena cava, sometimes occlusion of abnormal venous return, like azygos return, like superior vena cava, like some fountain circulation with sometimes extracardiac conduit, some patches. So it's very important to have a very nice definition, 3D definition of all the chambers, and to prepare the procedure to know where we can go and what we have to do to reach the substrate. You can see here in the screen some extracardiac conduit with a puncture, with a necessity of dilatation to reach the cardiac chamber. More classically, you can see puncture with an ASD device, and on the left, some puncture in a patient with atrial switch, with patches in the atrium with all surgery for transposition of great arteries. So we can have difficult access, but we can also see some problem with arrhythmia. Most of the time in this patient, we have 1, 2, or 3 arrhythmias. We can be in atrium, left and right, and which can be in ventricles. Another problem is the problem of tolerance of this arrhythmia. In the screen, you can see here macro-reentrant supraventricular arrhythmia in a patient with a mustard atrial switch for transposition of great arteries. When the arrhythmia begins, you can see the pressure. We have no pressure. So sometimes we have no time for extensive mapping. So preparing the procedure with some idea of the location, it's very important for the security too, for the procedure. Next slide, please. So with inHEART, with difficult access, you can see here a case where of a patient with a very complex disease. It's univentricular heart with a congenitally corrected transposition of great arteries, with a totally extracardiac conduit, with a lot of surgery, another surgery with auriculoventricular valve replacement with a prosthesis. You can see some some difference of in the ventricle. The problem of this patient was to reach the atrium. So with the screen, we can choose the location of the puncture to reach the atrium, to be not too close to the prosthesis, to the atrioventricular valve prosthesis, and to can move your and to prepare the displacement of your catheter in the atrium. Next slide, please. Also in this patient, after a lot of surgery, you can have some atypical location of a phrenic nerve in this patient, which was a conal cardiomyopathy. You can see the lead of the pacemaker. You can see all the coronary arteries. You can see the patches on the infundibulار trunk. You can see the patch on the interventricular septal defect, and you can see the phrenic nerve. In this patient, we need to perform ablation of the left in the left side for ventricle, because you can see you have a apical sequelae of surgery, and you can also perform and you need also to perform ablation for macro-entrant atrial tachycardia in the right atrium. Sometimes in the right atrium, you can be very close to the phrenic nerve, and to prepare the lesion set with the scan will be useful. Next slide, please. Another important location, it's coronary arteries. In this case, we have an Epstein patient with extensive surgery, with cone surgery, which is a complex tricuspid plasty with displacement of the annulus and modification of the morphology of the ventricle. We have a VT near, we have a VT, and we have also an accessory pathway. In this zone, after surgery, the wall could be very thin and very close to the coronary artery. So in this case, we can use the merge with 3D mapping and scan to choose the perfect location of the ablation site to avoid coronary damage in this patient. Next slide, please. An important thing too is to locate and to characterize the substrate for VT arrhythmia in a patient with a conal defect. The most common form is tetralogy of Fallot. As you know, the most important isthmus for ventricular tachycardia in this patient is the isthmus 3 between the VSD patch and the pulmonary artery. This isthmus can be very different in all the patient, with different thickness, with different location, depending on the location of the patch, depending on the successive surgery. Sometimes it could be difficult after surgery with homograph, with prosthesis, and sometimes with prosthesis with stent. And sometimes the stent can be in the isthmus and can take some problem to reach the substrate. 3D reconstruction with inHEART can help us, as you can see here, with the location of the different patches, and also with the location of the coronary arteries. Sometimes the right coronary arteries, not in this case, could be very close to the isthmus. So it's very important to merge the scan with the 3D reconstruction with electroanatomy to choose the location of the line to avoid some damage with the right coronary arteries. Also, with this analysis, you can have the length of the isthmus and also the deeper of the isthmus. And you can prepare your procedure with right axis and sometimes with complementary ablation, as you can see on the activation map, with location in the aorta. So a lot of things you can prepare before the procedure. Okay, next slide, please. In this patient, you can have very atypical substrates. This patient was a patient with transposition of great arteries with atrial switch procedure. As you can see, with atrial switch, you have some baffles in the atrium with new right atrium and new left atrium. The right ventricle is still in systemic position with most of the time very enlarged right ventricle and important trigger speed insufficiency. In this patient with no ventricular surgery, most of the time we have supraventricular arrhythmias, which can lead to sudden death, as you can see in the screen before, with no pressure, with high rate. In this patient, we have VT, and we understand VT with inHEART imaging. If we look at the location of a VT, it was close to the free wall of the right ventricle near the trigger speed annulus. And with the scan, we can see a scar. We can see a scar with very thin ventricular near the annulus. And it was a sequelae of infarction during the surgery, with no comment in any reports. Very important, because in this case, we have two possibilities for the access. We can access to the right ventricle with a baffle puncture, which can be difficult, and to reach just below the trigger speed valve, or you can reach retrogradely with the aorta. Here, we choose after analysis of the substrate, a retrograde approach to reach the substrate. It was an easy ablation at the end. Next slide, please. In this patient, as I tell you before, we can have a lot of atypical substrates. This patient was a tetralogy of Fallot patient. In this patient, usually we check for the same isthmuses near the ventricular septal patch, near the pulmonary artery. Most of the time, we don't go to this area near the trigger speed valve in the right ventricular free wall. After inHEART analysis, we can find another sequelae of infarction with atypical location near the basal portion of the right ventricle. So at the beginning of operation, we go directly to this zone and we gain a lot of time to take a precise analysis of this zone. Next slide, please. Okay, if you can activate the video, please. Yes. So we take a lot of time in this zone. we make the analysis of a scanner with different specific analysis of the scar, complex patient with a stent in the pulmonary artery. We induce a lot of VTs without isoproterenol. And you can see all the morphology are not typical for tetralogy of Fallot. We check for the isthmus-free with activation in sinus rhythm. We validate a complete block in the isthmus-free, and we look at the zone with the scar, and we have a lot of slow conducting zone in the scar with a nice correlation with the CT scan and with the inHEART analysis. We can make some activation map, quick activation map in the zone, and all the VT isthmus were located in the same zone. So we perform different ablation in the zone, and at the end, we perform a complete isolation of the scar. All the same location with an inferior axis. Okay, so we perform a complete isolation. Lesion at the end. Only one exit point, and with patient non-inducible at the end. Okay, next slide, please. So in conclusion, what we can say about ablation in complex congenital heart disease, there are challenging procedure with difficult access, atypical anatomies, multiple atypical substrate in the same patient. And 3D, CT, and MRI reconstruction analysis with inHEART system can be very useful in such patient with pre-procedural substrate location, especially for ventricle, but not only for ventricle, with pre-procedural choice of access. Very, very important in this patient because sometimes it's very difficult to reach the substrate. With pre-procedural location of critical structures like coronary arteries, phrenic nerves, to guide the line of ablation, and perhaps in the future, with evaluation of ablation lesion, especially for Fallot patient, can we have some follow-up with scan and analysis to check for the recurrences of isthmus. In our practice, actually, we think we have a gain of time in this very long procedure. We think we have a gain of success rate when we have a typical substrate. Typical substrate, I can see you, as I can show you in right ventricle. Thank you very much.
Thank you, Dr. Combes. I think at this time, we'd like to open it up to the panel. If there's any remaining questions.
I have a actually related question. So given these adult congenital patients with complex anatomy and perhaps many different hardware, do you prefer CT over MR? That's the first question. And the second question is, would you routinely request, characterization of the fat and calcium in these in your image results?
Yeah. Okay. Thank you very much for this very interesting question. For the CT and MRI, clearly, actually, it's easier for us to have CT. So we use CT because it's easier to have CT, and also with this patient with devices, with abandoned leads, with some fractured leads, sometimes we don't have good images with MRI. So in our daily practice, we use a lot of CT scan. Yeah, clearly. For the characterization of the substrate, we use a FAT. We use FAT in right ventricle, except in the condyle septum, because we have a lot of muscle, so we can have some, so it's enough. But in the right ventricle, FAT is very interesting for us.
Thank you, Nicolas. This was a great presentation. You beautifully showed how you can identify this and understand this unusual anatomy and the arrhythmic substrate. And I think this indication is really where there is a huge advantage of having that, because this can be nightmares. I mean, if you don't know the anatomy, don't know the substrate, it's extremely difficult. But when you have an idea of the anatomy, your access, and then when you can anticipate the area that can sustain VT, then it becomes pretty fun procedure. I don't know what is your opinion about that. And my second point, and you mentioned it, it's pretty even better than the surgical report, because sometimes the surgical report, you don't know whole, and you mentioned myocardial infarction, and with these images, with these inert images of this patient, you see all what is really there, and for that I like it very much. I don't know what is your opinion on that.
I have clearly the same opinion. I don't know in other countries, but in France, sometimes reports, the surgical reports, are very inconsistent. And when we perform imaging, days and years after, we discover a lot of things, a lot of problem with coronary arteries, a lot of problem with a lot of different incision, sometimes two, like in teratology of fellow patient. Sometimes the surgeon can perform an apical ventricular access, left ventricular apical access, and he don't tell you he have done this access. And sometimes you can have some VTs from the apex. And when you know that before exploration, because most of the time these patients have ICD, and you don't have the 12 lead ECG of a VT, you don't know where you go. You don't know if it is right or left. And if you have to map the right ventricle, the left ventricle, in an atypical anatomy, it takes a lot of time. So to know the substrate before, it's clearly more interesting and more amazing for us, yes. 10 years ago, it was a nightmare. Actually, not always a nightmare.
Well, thank you, everyone. Thank you, of course, to our esteemed presenters today for sharing your expertise and your experience with the inHEART solution. And thank you to all of our attendees, especially those that have stayed on to see all three presentations. We appreciate you joining us today. And if you do have additional questions on what you've seen today, please reach out to sales@inheartmedical.com. And to watch other webinars such as this, please feel free to visit the inHEART Medical website, which is inheartmedical.com. And when you are there, select webinars from the reference main menu option. So thank you, everyone, for joining us today, and we wish everyone a great day.
Thank you very much.
Bye.
Great
Thank
presentation.
you. Bye.
Thank you, everyone.
Thank you. Bye-bye.
Bye.
Goodbye, everybody.